All right. Thank you, everybody, for coming today. I'm going to start with some quick housekeeping. If you would like to have instructions to add French subtitles, they will be in the chat. So, les instructions pour ajouter des sous-titres français sont dans le chat. And the webinar is being recorded. Please change your screen name before using the Q&A feature if you want to remain anonymous, and you will not be able to write in the chat throughout the webinar, but we welcome questions using the Q&A button at the bottom, and we'll address them at the end. So thank you for coming to the Taking a People-Centered Approach to Achieve an Integrated Rehabilitation Program webinar. My name is Heather Scott, and I'm a third-generation settler living in Stony Plain, Alberta. I would like to begin by acknowledging that Treaty 6 territory, which I have been privileged to call my home for the last 42 years, is the traditional meeting grounds, gathering place, and traveling route to the Cree, Saulteaux, Niitsitapi, Métis, Dene, Nakota Sioux peoples. Today we are gathered virtually from across Canada, home to 70 treaty nations of the First Nations, Inuit, and Métis peoples. The Truth and Reconciliation Commission defined reconciliation in 2015 as the process of healing of relationships that requires public truth sharing, apology, and commemoration that acknowledges and addresses past harms. The truth is, Indigenous Canadians experience a disproportionately higher incidence of traumatic injury, including spinal cord injury, than other Canadians do. The challenges that Indigenous peoples living with SCI endure are exacerbated by historical injustices, social marginalization, and financial inequity. The new HSO Integrated People-Centered Spinal Cord Injury Rehab Standard offers guidance for designing and delivering care and services to marginalized groups. It is up to every one of us to continue learning about the beliefs, values, and identities of the Indigenous populations in Canada, and in an effort to advance reconciliation, to consciously strive towards creating and improving environments where everyone has access to the programs, support, and equipment they need to thrive after SCI. Praxis is committed to responding to the recommendations of the Truth and Reconciliation Commission and continually strives to better understand the unique needs and priorities of Indigenous peoples living with SCI, working together to address these disparities.
Welcome, everybody. My name is John Chinesky. I'm the manager of the Plex program here at Praxis. And I'm just going to run you quickly through what our agenda for today is going to look like so you know what's coming. Myself and Heather Scott have just welcomed you in. Immediately following me, we'll have Dr. Ian Rigby, who was heavily involved in the advisory committee, who's going to talk about the role of Plex as a driver of change and the importance of SCI standards in helping to facilitate changes in practice and ensuring equitable and optimal care. Following that, we'll have Peter Athanasopoulos from Spinal Cord Injury Ontario, who was the technical committee co-chair that helped to develop the standard. And he's going to walk you through what that process looked like in co-designing and developing the standard that we're talking about today. Following that, we'll have a recording of Andra Stanku from the Health Standards Organization, the organization that really led the facilitation of creating the actual standard. And she'll talk about what that process looked like throughout the many years that we've been working on this. After that, we're going to have Jeff Conway, an individual with lived experience in Newfoundland, who has been a powerful advocate for the voice of Plex and helping to advocate for change. And alongside him, we'll have Amy Prince from the LA Miller Rehab Center in Newfoundland, talking about how they've taken a very proactive approach in already beginning the implementation of the standard to help change practice in their province. And then lastly, we'll have Aaron McCaddy from Accreditation Canada, the body that helps with the actual implementation of the standard and provides the assessments that need to be done to achieve accreditation's recognition, and then we'll wrap up with a Q&A. So as Heather mentioned, if you have any questions throughout the webinar, you can use the Q&A button down below, and we will triage those, and we'll have time for Q&A at the end. So given that we want to try to squeeze all of this into 90 minutes, let's jump forward, and I'll introduce Dr. Ian Rigby.
Awesome. Thanks, John. So yeah, as John had mentioned, my name is Ian. I'm a physician here in Calgary, and as John mentioned, a person with a lived experience of spinal cord injury. And myself, along with Ms. Chloe Angus, had the great experience to be co-chairs of the advisory committee portion of the standards development. And this morning, I really have the opportunity to speak to you a bit about the utility of standards and their use. And I'm going to keep this mercifully short because I think there's going to be lots of really good discussion as we get much more into the specifics of the standards and their application. But really to kick this off, I do actually want to start by saying a really heartfelt thank you to everyone who's on this call. I mean, if you're on a Zoom meeting about the new and updated rehab standards for SCI, you're only here if you are a champion for spinal cord injury in your organization. So whatever your role is in that organization, I do want to say thank you for everything you do. What you do really does matter to people like myself and our SCI community. And I really want to say thank you for taking the time to get to explore these standards and consider them as a tool for advancing the programs that really do impact our care. And I suspect many of you on this call have been part of a standards-based assessment or accreditation. I certainly have been a number of times in my role as a physician in our ERs here in Calgary and as a previous residency program director. And I suspect, like many of you, perhaps my initial view of standards-based assessment was similar in that I would say it was kind of one of a mix of frustration and trepidation. Frustration in sort of the amount of sometimes the work and documentation we do for our programs, even when we're part of a really strong program. And of course, some trepidation in that we all want our assessments and evaluations to be glowing and positive. And so we're always a little worried about those outcomes. Having said that, I really do recall when my views on this had changed, and I was having coffee with I'll say a more seasoned colleague of mine a number of years ago. We had just finished our residency program accreditation, and I confess I was probably bemoaning the amount of work that had gone into that. And in that discussion, he really opened my eyes about 2 points. And and the first thing he had asked me was, is despite having inherited, a really strong program, had the experience of going through the standards really changed, what we had done in our program? And the answer, of course, to that was yes. We'd revamped our program's academic days a lot. We'd changed some rotations and evaluations. And it really got me thinking about how, programs, in general evolve due to all sorts of kind of unusual forces, right? So it could be one-off events that happen in programs. It could be due to the effects of some of the strong personalities in those programs, maybe unplanned opportunities that arise. And on reflection, working through a set of standards, it was really an opportunity to reflect globally on our programs and really to make them develop and really evolve in a thoughtful manner, as opposed to a bit of the reactive kind of approach that we have due to the day-to-day events of our programs. The second insight that I gleaned from that conversation was probably not one I would have reached on my own. And my colleague had shared the fact that years previously, he had been involved in an accreditation that went perhaps a little bit poorly. The programs had been noted to have a lot of deficits in the standards. They had actually been put on probation. And he shared that although this was somewhat emotionally difficult for everyone involved, it really unlocked just a slew of extra resources for that program. So A number of the colleagues of that program suddenly stepped up to take on new roles and new undertakings to address some of the challenges and deficits. And in this particular instance, the university offered a considerable amount of new resources and expertise. And actually, that program was able to address, a number of issues that they had even felt was intractable in their program. In the end, really, that program got back on accreditation and really improved the experience and the outcomes of the folks it served. And so, I want to say that, yeah, I need to acknowledge that working through a standards-based assessment can be a lot of effort. There's some maybe emotional risk involved, but really, this is a tool and a really powerful one to drive thoughtful change to the experiences of those people that our programs serve. And this, I think, brings me back to my thank yous. Everyone on this call is the driver of change in your programs. And we in the SEI community, of course, are the beneficiaries of your efforts. So I think I would like to end by saying thank you for what you do, for getting to know and explore these new standards, and really considering them as a tool to really improve the outcomes for the people you serve, which of course is myself and my colleagues. So thank you for joining us today. And I think with that, I will hand this back over to Heather and John.
Thank you so much, Ian. Yeah, I think we do see the standard as a way to really facilitate change right across the country, and we're very hopeful that all the specialized centers across the country will adopt this new and very robust standard. Now it's my pleasure to introduce Peter Athanasopoulos. So Peter was the technical committee co-chair, and that was a very vast team that really came together to develop the standards. It was quite a long process, and we're extremely grateful for their commitment of everybody on the technical committee who worked so hard for such a long period of time to review each and every single word in those standards. And as you'll know, it's a very long document. As you can see from the bio, Peter's been living with a spinal cord injury for quite some time. He is the Director of Public Policy and Government Relations at Spinal Cord Injury Ontario for the last 25 years. And he's also involved in a variety of various committees in Ontario. And as I said, co-chaired the technical committee with HSO in developing this new standard for Canada. So without further ado, I will hand over to Peter.
Sorry about that, I was muted. Thank you, John, for your introduction, and as well, Ian, for your very thoughtful remarks. It certainly takes an army to build this standard assessment to true fruition. And one thing I always say about our spinal cord injury community is we're very privileged in the sense where we have such a huge, caring, and compassionate group of leaders across the country who simply want to make the best outcomes for people with spinal cord injuries. And that spoke loudly with Ian's remarks, and definitely for myself and for all of you on the call here today. Thank you so much for your commitment. As the co-chair of this technical committee, my colleague and I, Kathy Kozak, had a few objectives that we wanted to achieve in terms of bringing justice to the outcomes of the technical committee. And the first objective was that we wanted to create the most optimal SCI recovery through a people-centered standard development approach. And in order for us to achieve that, there was a few things that were really important to us in our decision making when a lot of the technical committee members were having suggestions, ideas, and sharing their expertise in order to fulfill the standard development assessment. And the first one was balancing perspectives. Recognizing that we had three main cohorts in the technical committee. We had a variety of different researchers that providing evidence-based practice, historical research, that drove some of the decision making that would build the standard development. We had a larger clinician base overall in the technical committee, and then the third cohort were people with lived experience. And how do we create decisions where we're balancing what the research is saying, balancing what the clinicians have been repeatedly seeing in their practice, and balancing the perspective of people who are using the services every day? So that was really what the lens in which we took, Kathy and I, when we were adopting and reaching consensus within the standard development process. So we hope those three areas and the balance of those perspectives are really reflected in the end product that you see today, because that was a key component of ours. Um, the second piece that was really important to us from an evaluatory perspective was ensuring that there was evident transitions from acute care to rehabilitation into community. And with respect to the community, what we were really looking for is partnerships, recognizing that this is primarily a hospital accreditation intended to go beyond hospital, but recognizing that that the primary audience and client to this standard development was a hospital base. So while you'll see the standard assessment quite compartmentalized with respect to what the deliverables look like from an acute care to rehabilitation and how discharge planning works in the community. Um, for obvious reasons, there needed to be some compartmentalization, recognizing the expertise lies within those that are working within those spaces. But really, what we're trying to do is create those seamless transitions from acute to rehabilitation and in the community, and look at the standard assessments tool as a whole, as opposed to what checkbox needs to be done in acute care, what checkbox needs to be done in community, in rehab and in the community. So when using the tool, really try to reflect beyond your scope of practice and what the intent of the standard development is intending to do across the continuum of care. One other key component is worth noting, and particularly around partnerships, is the availability and creation of peer networks. We've not seen this standard development in previous standard development tools, particularly in the SCI, or maybe there have been, but not as prominently shared. But this standard assessment does expect hospitals and rehabilitation centers to engage in partnerships with spinal cord injury organizations or other disability organizations to really establish peer networks when people leave hospital. There's some really great partnerships. I know with Spinal Cord Injury Ontario and the spinal cord injury rehab programs across our province have really strong relations, and we work together. And that's been one of our highlights in previous accreditations that we've done. But we've really tried to create this as standard across the board, across the country. When looking at the standard, really reflect on those aspects of partnerships, particularly around how powerful it is for an individual to have a social network of people with spinal cord injuries when they're home and living independently and striving to overcome challenges that they've never experienced before. This introduction of peer networks starts in the rehabilitation phase, really, when people get accustomed to sharing their challenges and tribulations in their recovery process. And we hope that this accreditation can create some assessments on where we can demonstrate the continuation of those standard developments into the community. Last but not least, another important area in the extension to the community is those essential needs that people require in accessible housing. How well can the rehabilitation programs set people up for success with respect to essential needs like assistive devices or environmental controls, ensuring a person's home is inaccessible. I recognize that a lot of the rehabilitation programs don't have any control over these things, but at the same time, partnerships do create those avenues to create those successes. So this assessment tool really speaks loudly around partnerships and making sure that that continuum of care happens into the community so people can live a successful and rewarding life after a spinal cord injury. So these are some tidbits that I'm hoping people will capture when they're applying these assessment tools, and really was important for me as a co-chair of this technical committee. And we've had various discussions during the technical committee process in bringing these aspects that I've just shared with you to life. So again, thank you for the opportunity to be involved in this process, and I hope we've done you all justice in this development of accreditation, primarily in taking pride in developing something that was solely and truly a people-centered approach.
Thank you very much, Peter. Thank you very much for that. I'm going to move on to Andra. Just looking at our time here. Andra is from the Health Standards Organization, and she's a Senior Program Director, Standards at the HSO, combining skills in research and content development, project management, and public engagement. Her academic background is in global health, and she's most recently worked to improve health equity through rights-based advocacy prior to joining HSO. She is delighted to be working alongside Praxis colleagues and technical committee members to support awareness and uptake of the recently published National Standard of Canada.
Thank you so much for the opportunity to present today on co-designing the integrated people-centered spinal cord injury rehabilitation program standards. My name is Andra Stanku. I'm a senior program manager with Health Standards Organization, and it's an honor to be with you today on behalf of the HSO project team that really led the development of the standard in collaboration with Praxis. So a bit about who we are, and I'll just take a moment to highlight that people-powered health really pertains to people receiving care as well as providers as being at the heart of what we do. And I trust you'll see this woven into our collective work throughout this presentation. So I'll first start off with HSO. HSO develops the evidence-informed quality improvement solutions like standards that can be used by organizations around the world. We are a standard development organization that are accredited by the Standards Council of Canada, which is the Canadian representative to the International Organization for Standardization, also known as ISO. So we really develop the evidence-informed technical content that is then mobilized by Accreditation Canada to client organizations. So on the other side, Accreditation Canada works with the health and social service organizations to support their implementation of standards through customizable accreditation programs. Together, we bring standards to life. Now, the partnership with Praxis began around 2019 with this first deliverable, a needs assessment. And through this work, we received 159 completed surveys, 38% of which were from people with lived experiences or caregivers. And respondents also included healthcare providers, that's around 45% of responses. There were hospital administrators with about a 7% response rate. Community representatives of the spinal cord injury community around 6%, and researchers as well as people who identified as other. So on the basis of these surveys and also some follow-up interviews, we developed a summary report, which you can download using the QR code on your screen. And I'll just highlight one of the 5 insights. Access and navigation of care is a significant challenge when people transition out of rehab. So we'll come back to this a little bit later on in the presentation. Now, of the 159 respondents, we then invited people with lived experience to participate in focus groups that utilized photo voice methodology to develop a journey map. Participants were asked to bring photos taken in the 0 to 18 months post-rehab and use them to describe 4 aspects of their journey: feelings, goals and activities, pain points, gaps and barriers, and any ideas for improving the experience. These experiences and perspectives were developed into a journey map that you can access using the QR code on your screen. Now, when I say we, I mean an entire team of subject matter experts and thought leaders. In fact, more like 2 teams. So I'll just highlight here and take this opportunity to share my sincere thanks to our advisory committee that was more involved throughout these early deliverables. And that included 13 members, 4 of which were people with lived experiences, and that includes both of the co-chairs of the advisory committee. For the next stage of the work that we'll talk about in a moment, we also convened a technical committee. Now I'll talk more about the role of the HSO technical committees in leading content development, but suffice it to say that these 24 members, 8 of which were people with lived experiences, and 1 of them was the co-chair. These were really the empowered decision makers. So we recruit across 4 interest groups: people with lived experience, policymakers, product users, as well as researchers in industry in a general interest category. And really the decision making as to, approving content or not lies with this committee. And so I hope you'll see from this slide that many people, many perspectives across Canada and across different interest groups are really represented. And I have also added one of my colleagues, Louise Clement, and there were many others on the HSO project team and many colleagues that contributed, but I did want to call out her extensive contributions throughout this project as well. So when it comes to the really what we're celebrating today is the delivery and the completion of a national standard of Canada. And our national standards, if you're not familiar, are developed with a rigorous process that's required of a standard development organization like HSO. And so some of the components of that include, as I mentioned, the technical committee approval, consensus approval of content. We did also consult with the advisory committee on what we were producing and developing. We also held a public review where we received over 100 comments from the Canadian public and I believe some international submissions as well. And as a continuous improvement process, we do solicit feedback and we do track any complaints and appeals from the public. And all of our national standards do undergo a maintenance period. So every 5 years or so, we do check in to see, does the standard need to be reviewed or what makes sense given the current landscape and the public need. So on the basis of that national standard, there was also an assessment standard that was developed, and that's available to clients across Canada in over 12,000 locations globally. And all Accreditation Canada client engagement leads support client organizations to ensure that they're preparing, and it's a kind of a coaching model to support organizations to fulfill and to respond to and to comply with the standards upon which they're being accredited. And surveys can be done by patient and or peer surveyors. So that's a really interesting way that we like to integrate, the perspectives of people with lived experience as well in the surveys and in the assessment of organizations. So I do invite you to download your own copy of the standard. It's free of charge, but I want to provide a high-level overview of the key concepts that it addresses. So first, with regard to an integrated approach to care, and that's supported by comprehensive collaboration across system partners and partner organizations. Next, people-centered care, cultural safety and humility, the concept of IDEA or inclusion, diversity, equity, access as essential principles that are really embedded in organizational procedures and policies. Comprehensive assessments are guided by the latest evidence, so the standard itself cannot be prescriptive in terms of technical direction or clinical guidance. However, we refer to SCIRE and CAN-SCIP guidelines for that supplementary instruction. Co-designing the individualized care plans with the person receiving care and or their designated support persons, particularly around transition planning. And remember, this was one of the key outcomes of the Insights report that I mentioned earlier. And finally, quality indicators are a critical part of standards and accreditation. It's a mechanism by which organizations can benchmark and form a foundation for continuous quality improvement. Now here's an example, criterion 1.2.1, and this top line here provides the content that would be assessed. And the accountability you'll see lies with the organizational leaders. The action that's being required is co-designing the program with stakeholders. And the outcome is the alignment with biopsychosocial framework. So that provides a kind of holistic view of the needs, goals, and preferences of the individual. The guidelines are informative and they provide helpful context to the organization during assessment. And they talk about why is this important? What are the best practices currently that organizations can use in this topic? And how can you as an organization demonstrate that you're complying with this criterion? Now, finally, since the public release of the National Standard of Canada earlier this year, all Accreditation Canada clients globally now have access, and over 70 individuals have downloaded their own copy of the standard to drive quality improvement in their organizations, or perhaps for curiosity. And I trust this number will go up following today's discussion. But I really want to thank you for your attention. And should you have any questions or wish to learn more about this work, here's my contact information. Thank you.
Awesome. Well, I hope that gave you a bit of insight into how HSO works to develop the standard and all the various folks that were deeply involved throughout the entire process. As you, I'm sure, heard, it was a very rigorous process, a very stepwise approach with obviously understanding some of the needs and getting some background information and then a deep level of consultation with experts from across the country to come up with a standard that we feel is going to meet the needs of our clinical partners across the country, as well as individuals with lived experience who are interacting with these hospital systems on a daily basis. Next, I'd like to introduce Jeff Conway, again, an individual with lived experience of SCI. He lives with a T12 injury in Newfoundland and Labrador, and he's a very powerful advocate for system change. I think the experiences that he had interacting with the healthcare system in Newfoundland were perhaps less optimal than he was hoping them to be. And so working along clinical champions inside Newfoundland that we'll hear about shortly after Jeff's recording, he'll talk a little bit about the work that they've done to try to create an urgency for improvement in care standards in his home province. So without further ado, Heather, if you can start that recording, please.
First off, I'd like to thank Praxis for the opportunity to make a contribution to this webinar. A little about me for context. So I experienced a T12 spinal cord injury traumatic about 5 years ago. And what I encountered along my journey were generally very caring clinicians who at the same time seemed to lack many of the policies, procedures, and clinical practice guidelines that would have supported them in their work. They also lacked a lot of the equipment that I think would have supported them in their work. And so after I was injured and I had some time, I started to do some research into how to contribute to remedying that. And I think that's really what started my role as something of an advocate in Newfoundland and Labrador, to try to affect some of that change. And one of the first things I found was that our health authority wasn't accredited, specifically in spinal cord injury standards of care. I also found that we were the only Atlantic province that was not a member of the IEQCC. We had no dedicated spinal cord injury navigator, no FES bike, no standing frame, and our province only provided 8 catheters a month to persons with spinal cord injury under the public program, which, as I'm sure you know, is not only woefully insufficient, but also, compared to other jurisdictions, extremely low. Another thing I found in my initial research was that over a period of 5 fiscal years, there were less than 5 persons referred out of province for the following services: exoskeleton usage, implantable spinal cord stimulation, FES bike therapy, and spinal cord injury clinical trials. So essentially what we were left with was not only not having these services as one might expect for a smaller jurisdiction, and perhaps that's understandable, but people in this province were not being connected and sent to those services out of province. So it's as if they didn't exist to us. And I can only speak from my experience here, but I would posit that outside of the Golden Horseshoe, Lower Mainland, Calgary, Edmonton corridor, I think it's fair to say that a large chunk of Canada, it's possible, may be in a similar situation, which I think underscores the importance of having a national standard of care and the work that's being done with this standard. And I think it's suffice to say I didn't find that status quo acceptable. And I'd like to share with you today, and I think that's why I was invited, a few of the specific things that I did to, as I said, try to affect some of that change. So the first was I really tried to identify the problems that I saw and to leverage initiatives like this draft standard, well, at the time draft standard, in order to help solve those problems. So after the draft standard came out, and I took a look at it, one of the observations that I made was that it didn't appear that we even offered many of the services that existed in the draft standard. So things like annual neurological assessments, functional assessments, nutritional assessments, bowel assessments, breathing and respiratory health evaluations, as I said, implementation of standing program with standing frames, and incorporation of electrical stimulation and exoskeletons into care. So whether the increments were biannual, semi-annual, annual, it didn't really matter much because we really didn't have a consistent rollout of those services for people who were rehabilitating from spinal cord injury care. And again, and I can only speak to my own experience, but that's what I encountered. The second thing I tried to do, and I think this is where Praxis came in, was to build allies, and particularly the data services team at Praxis. So I had all this anecdotal experience, having been an inpatient for more or less half a year, and going through all the different phases of rehabilitation. But what I wanted to do was obviously have some data behind that. And so when I reached out to the data services team, I said, listen, I feel like we're behind in these particular aspects of care, and I'd like to know a bit more about the outcomes. So they connected me with some of the data in the Rick Hansen registry, and they essentially helped to visualize that data for me and to prepare a report so that not only could we see what those outcomes were, but how we were performing vis-a-vis other jurisdictions in the country. And again, just speaking for myself, but I would assume that many of the people that I shared that report with Praxis's permission, had never really encountered that before. You know, a person with spinal cord injury who came with that level of evidence. So, you know, again, the research I'd done on my own, the peer-reviewed articles, but also that very specific report from Praxis, you know, that spoke about, you know, outcomes in urinary care, all the different standards of care. And I'm not a medical professional, but I found it very sobering. And I felt like that was a very effective collaboration where, again, Praxis did the lion's share, but you know, I helped shepherd that process along. So from an advocacy point of view, I think that was very effective. The third thing I really tried to do, and this may be obvious, but to use my role as an individual to help facilitate change. So many of the people that are on the call here today, I'm assuming they're doing that, you know, in the context of their employment. So clinicians, healthcare administrators, even staff members from advocacy groups, you know, you may all have very informed and strong personal opinions, but I think in most cases you're also constrained by a duty of loyalty to your employer, an expectation of not being overly critical of your employer or your province in some situations. And so I think what that creates sometimes is an atmosphere where there really isn't a situation of being full and frank with criticism sometimes. And I guess circling back to the draft standard, when I made my comments on the draft standard, I really tried to emphasize the importance of the individual. So not only from the perspective of agency, like obviously empowering an individual with spinal cord injury to speak up for themselves and for their community, but also to understand the real benefits to the system of having that individual. Because again, in my own experience, I believe that many of the people that I dealt with, whether it was our health authority or with the province, you know, perhaps were not as familiar with that type of full and frank discussion. And again, always respectful, but full and frank. And I think that's somewhat unique. So stakeholders are obviously extremely important, but let's not forget the role and the power of the individual. The fourth point I wanted to make was, and again, this is my own experience, was I think it's very important for us to bear in mind that we are a nation and we're united by things like the Canada Health Act. So yeah, one of my experiences was that I was looking for a particular aspect of my care that wasn't available in this province. And so I obtained a referral from a specialist. You know, he sent that to a rehabilitation center. And more or less the answer that I got back, as I understood it, was that you know, the focus of their care was going to be on patients in their province. And I was very surprised by that because, as I mentioned previously, many of us aren't fortunate enough to live in places like Toronto, Vancouver, and we rely on, you know, I think the fact that we're a country, and that I'm assuming most of rehabilitation centers are funded in one way or another, you know, through transfers from the federal government and are subject to the Canada Health Act. And I think it's very important that we remember that there is this collective obligation to care for people with spinal cord injury. And hopefully something that will come from a national standard like this and increased accreditation is a reminder perhaps that, you know, even if your rehabilitation center is, you know, in a particular city or particular province, there are many of us out here that don't have that access. And please don't forget us. And I think perhaps the last point I'd make is really about connecting the issue with the right decision maker. So, and again, this is just a very anecdotal example as well, but I'm not the type of person who really felt like I had to engage with the system, engage with bots or complaint lines, and wait for a month for someone to call me back. Even when it comes to advocacy, I didn't feel like I had to be subject to my health authority screening me and vetting me and deciding whether or not I was suitable to sit on a committee. So, in my case, I knew that our premier was also an orthopedic surgeon. And I also felt like if anyone in this province would understand and have an interest in people with spinal cord injury, he would be such a person. And so I think, let's not forget the power of really just finding the right person to hear your concern. And again, I've found value in that. And to kind of bring it all back, 5 years later now, and you'll hear from other people on this panel, like our new navigator, but as far as I understand it, we now have an FES bike in this province. We're becoming a member, or we are a member of the IEQCC. We're committed, as I understand it, to pursuing accreditation under this new standard. And just weeks ago, I received a letter that our intermittent catheter coverage is very likely going to be increasing from 8 per month to 60 per month. So I'm sure I played a minuscule role in those developments, but hopefully I did play some role. And, I hope that other people with spinal cord injury feel free to pursue that advocacy as well. So thank you for your time. I appreciate it. And good luck. Thank you.
I'd just like to thank Jeff for providing that pre-recorded perspective on his journey as such a powerful advocate. I think he maybe undersells the role that he played a little bit. I think his voice and his actions have been very, very powerful in influencing change in Newfoundland. And now we're going to hear from his partner in helping facilitate that change from a clinical perspective. Amy Prince from the LA Miller Rehab Center in Newfoundland and Labrador. She's currently the SCI Navigator Coordinator there in St. John's and is a Master of Occupational Therapy with over 15 years of experience working in SCI in rehab and complex seating. And her focus is obviously on ensuring quality care throughout the journey and on process improvement and quality care for individuals living with SCI in Newfoundland and Labrador. And I think as a compatriot of Jeff's and trying to facilitate change, Amy's played a powerful role in helping to get this change in practice started in Newfoundland. So without further ado, we'll hand over to Amy.
Thank you so much. I'm just going to try and share my screen here now and start this. Can everyone see that okay?
I think you're still
Oh,
in
I might be.
view.
There we go. Can you see that okay?
We can see it, but we see your full slides. It's not like the presenter view. It's sort of the editing view.
It's showing that it is.
Yeah. I think we're on the presenter view where we can see your notes and such. So maybe it's on a different screen. I don't know.
Okay, just 1 second now. I'm not sure why this is not letting me do this.
That's okay. I mean, you can't go through any webinar without some technical.
I'm just going to stop sharing for a second. Sorry about this, and see if I can get it to work better. I tried this earlier and it worked fine, so I'm very sorry.
No, that's okay. We got plenty of time.
Okay, I'm just going to move this because I think this is part of the problem. It's up here in the corner.
For slideshow.
Is that still there?
You know what? I think it'll work. It's still showing like the full PowerPoint software piece. It's not actually showing in presenter view, but it'll work. I think we'll be able to catch it.
Okay, sorry about that. You'll see my notes on the side. So just I wanted to thank you everyone for letting me present here today. Just wanted to give you a little overview of the structure of the Miller Center. So the Miller Center does provide primary and tertiary rehabilitation for the entire province of Newfoundland. And we are the only facility within the province that provides spinal cord injury specific care. We do inpatient, outpatient, complex seating, orthotics, rehabilitation medicine, and we do offer some travel clinics that we throughout different areas of the province. We typically see about 20 to 30 spinal cord injury patients a year. The majority of those seem to be more recently in the non-traumatic. And we do have periods where there are smaller numbers on our inpatient unit, or some periods where there's none at all.
Amy, we're still seeing your title slide. It doesn't seem to be moving down. I think you're just finished slide 2, right?
Yes. Are the slides moving now?
No, we're still on your title slide.
Okay, it's all moving on my screen.
I wonder, does Heather have a copy of your slides? Maybe she could do a screen share.
It doesn't.
All right, well, now we're in presenter view, and I think that'll work. That's good enough. We can see your
Is-
notes, but that's okay.
Is this okay? Can you see now?
Yeah, you're on rehab structure now?
Yeah, okay, I'm moving to the next slide now.
Perfect. Spinal cord
Okay.
navigators.
So just to give a little bit about my role and how it came about. So it was identified through feedback from patients and clients, staff, and you heard from Jeff, and through even just our regional clinics where we went to other areas of the province, that there was a gap in service for spinal cord injury patients along the continuum of care. So during this same time, we also noted that we had a very large turnover in our inpatient staff. It was allied health, nursing, and physicians. And the majority of those individuals, including myself, had been on the unit for most of our career. So you were looking at a huge loss of experience around that same time. Over several months, attempts were made to complete this work. However, it was mainly being completed off the side of a desk as time allowed, and there wasn't really much success happening there. So this led to the creation of my position, which is a position that's focused on improving quality care for individuals with spinal cord injury. So, as we know, that our quality improvement journey is a work in progress. It involves multiple steps and a lot of follow-up with the overall goal to achieve all aspects of the HSO standards, so for Integrated People-Centered Spinal Cord Injury Rehabilitation Program, and SCI accreditation. I will say that right now our province is actually changing over to one health authority, which means that there'll be some changes in terms of our rehab accreditation. And our provincial accreditation standards planning committee have already reviewed and determined the standards for this cycle, and the SCI one was not one of the standards. So how did we start this process? So where did we start? We looked at our current state. So our current state, there was no real clear chain of care or pathway of care specifically for inpatient rehabilitation. And that's kind of where my focus has been right now presently. And a lot of people, their experience was more of a case-by-case basis. So not everyone received the same experience. There's no transitional pathway of care from acute care directly through the system to community or primary care. There was no real set criteria for follow-up post-discharge. And when you spoke with patients, they felt really unprepared for what to expect through the continuum of care and how their care needs were going to be managed. We also found that teams were often working in silos. So we might have our acute care team, our primary care team, and then our rehab team, but not necessarily all within the same page. So this led to the develop of our chain of care for inpatient rehabilitation. So this is presently used as a draft form, and it was developed in collaboration with our staff here at the Miller Center, our spinal cord injury working group, and our patient advisor. It incorporates the current HSO standards, and within this, we've been working on including developments of order sets, policies, medical directive, consults, assessment forms, education, audit tools, outcome measures. What you're seeing on the screen here is an example of what we want to present to the patients and family, as this is what your stay in inpatient rehabilitation should look like. But we also have a more specific, detailed pathway or chain of care for our inpatient providers that incorporates more specific elements and timelines that need to be completed. So our next step was setting our targets for improvement. We have this care chain, we put it in use, we put it on the charts, but how do we make sure that everybody can use it? And this is where we shifted our focus to two main areas of the standards, including enabling a healthy and competent workforce and ensuring a comprehensive assessment, specifically around bowel function. We know that there are several areas of opportunity for improvement, but we could not tackle everything at once, so we focused on these two main areas. Why we focused on these? Well, again, we had a high turnover in staff, which meant a loss of experience. We had roundtable discussions with staff and identified that many did not feel very confident in all aspects of the chain of care. We also found that there was inconsistencies in its use and documentation. So, once our target area of enabling a healthy and competent workforce was set, we looked at developing a self-assessment tool starting with nursing staff on competencies we felt were important for working with those individuals with spinal cord injury. We had the nursing staff, complete these anonymously. Then we used the results of these assessments to determine what areas of education we should look at. We met with the nursing staff also to determine the best way they felt to deliver the education. So again, this really goes back to the PDSA cycle. So when we met with staff, our nursing staff felt that discussing client cases was the best way to learn, and they felt it was more relevant and engaging. They also felt in-person discussions were more beneficial than online learn modules. They felt they would be more engaged and pay more attention. So from this self-assessment tool, we picked one area. So what we chose more recently was spasticity. So that was an area that staff felt that they weren't really confident in. So with that, myself, a physiotherapist, and our nursing educator developed a case study based on a previous client who had been admitted to inpatients who had concerns around spasticity. We went to the nursing unit at a time when they were less busy and everyone was able to be engaged. It actually ended up being on a weekend, but it worked really well. And we worked through the case study with the patients. So we talked, or with the staff, we talked about what the issues were. We talked about what they could have what they can expect with someone at a similar level of injury, and how to better manage this going forward. Then we went back to the nurses and asked them how they felt about it. The feedback was really, really good. They all felt very confident. They felt like they had learned a lot. It opened up discussions about more individuals on the unit who they felt they were struggling with. And it also looked at more of the use of language. So what way we should, how we should present the patient to even the physician, so they know that, you know, this is spasticity, not just stiffness or a pain. There's other things going on here. And then we are now in the process of developing self-assessment tools for all other individual disciplines. So we have them for PT, OT, rec, nursing. We're looking at them for dietitian, psychology, social work, everybody. And going to use this also as an orientation tool, so that when someone new comes, they'll complete this self-assessment and we can provide them with that education right away. So once this was completed, we further looked at ensuring a comprehensive assessment, specifically around bowel function. So again, through our review, we determined that bowel management was an area that clients and families were struggling with, both while inpatient and post-discharge. During inpatients, we were providing education and developing bowel routines, but we felt we could be doing more to ensure that it was a more comprehensive assessment and that we were doing follow-up while they were here. This led to some extra developments, such as our joint assessment form, which has more specific questions around bowel management, both currently and prior to admission. We initiated a weekly bowel and bladder rounds. This includes the physician, our patient care facilitator and a nurse, our dietitian, our pharmacist, and we look at discussing the bowel programs weekly in a more thorough and concise manner. With that, we also developed a bowel retraining chart form. So this is something that staff complete regularly. We were using a form before, but this one is more specific detail on time, consistency, incontinence, whether they were independent, what medications were used, so we can better track and better discuss bowel programs. We're also currently initiating an Asia huddle. So this is where our physiotherapists will go to the unit with the nurses, review everyone's admission Asia when they first come in, and discuss how this might impact their care, and specifically also around how it may impact their bowel function. We're also developing, and it's in draft form, an interdisciplinary bowel management policy. So this is where we look at it as a team effort, right from the pharmacist to what medications, to the OT, to what commode they're on. We are kind of doing it anyways, but this puts it more in a standard of practice so that we are doing it all the time. So where do we go from here? Again, this is an ongoing work in progress, and our focus does still remain on putting in place and enabling a healthy and competent workforce by using our competencies and self-assessment tools to assist with further educating and orienting staff. Once we have ensured our countermeasures for a comprehensive bowel assessment are successful and sustainable, because that's important, we will move on to other assessment areas, such as pain, bladder management. We'll review then and see what's the next one. We continue to strive to include the individuals with SCI in all aspects of their care plan. And we are now in regular contact with our acute care, primary care, and community partners with the final goal of a transitional pathway of care across the continuum. I do think it's also important to mention, kind of in what Jeff said, we have done some other things that are smaller projects, but we've implemented a patient-oriented discharge summary. We have joined the IEQCC and have started implementing the community participation domain of care. So there's other extra things that we're kind of doing on the side as well as implementing these. Any questions?
So thank you so much, Amy. I think we'll be doing the Q&As at the end. So just a quick reminder to everybody, if you have any questions throughout the webinar, you can use the Q&A function at the bottom of your screen there in Zoom to submit them, and we'll be asking the panelists to respond to the questions at the end of the session. Heather, did you want to introduce our final speaker?
Absolutely. I'm unable to see if people can hear me.
I can hear you just fine.
Okay, perfect. Thank you. All right. So up next, we've got Erin McCaddy from Accreditation Canada, and she joined Accreditation Canada in May 2022 as a client engagement lead after 22 years working in Ontario healthcare. She's a registered kinesiologist and has spent most of her clinical years working in the ambulatory care programs, including orthopedics, cardiac, pulmonary, stroke, and spinal cord rehabilitation. And she's also had leadership roles within regional health centers. Sorry. Erin has a passion for driving best practice and quality improvement in our healthcare system. And without further ado, I will turn it over to you, Erin.
Perfect. Thank you so much. Can everybody hear me okay? And thank you for this introduction, and listening to this webinar makes me want to go back to clinical practice and using these types of standards as a lever for change in organizations, which is really what led me to my role at Accreditation Canada, was being that leader in a healthcare facility and using standards as a lever for change. So good afternoon, good morning, depends on where you're joining us from. I am from snowy Ontario, just outside of Toronto in Peterborough, Ontario, and it seems to snow and snow and snow and snow and snow, and I have never seen so much snow in all my life. I don't know if spring is ever going to get here fast enough. But I want to thank Praxis for inviting me here today. As Heather introduced me, I am a client engagement lead here at Accreditation Canada. And really my role here today is to talk and speak with you just about now that you've learned all of the great things about these standards, how they were developed and the teams that put them together, how can I use these standards to be assessed? So I won't take too much of your time, but I just want to point out a couple avenues. The first avenue is actually on the right-hand side of your screen, and that is for organizations who are already a part of an Accreditation Canada program, either already accredited or on their journey of being accredited through Accreditation Canada. And that is really to reach out to your client engagement lead, someone like myself, or a client engagement team member that you're working with or that your organization works with, because how you're going to use the standard and how you can be assessed as standard really looks very different for everyone and every organization, and where you're at in your survey cycle, what type of survey cycle you're on. So the best avenue is to reach out to that client engagement lead. And if you do not know who that is, please contact us. Going online, Googling Accreditation Canada, reach out to the business development team, and they will connect you with your lead associated with your organization. Okay. So if you're not a part of Accreditation Canada already, and you're looking for more information, I'll draw your attention to the left-hand side of the screen. And that is really, I would start out by Googling Accreditation Canada, or go on the website URL is listed there. And that is reach out, and there's an option to connect with an advisor, and they will be the one to best answer your questions about how do you get involved? How can you use these standards? As Ian said, nobody really loves an accreditation cycle in a survey, and there's a lot of work that it goes into that, but it's amazing the result that you can get at the end, and the buy-in from your leadership when you go through something like this. So reach out to us depending on your organization. whether it's a hospital-based or any health and social service organization, will really depend on what this looks like. So reach out to us. Our business development team will connect you to the right individual that will be able to answer all your questions. So I think that's all I had, Heather.
Awesome. Thank you so much, Erin. Short and sweet, but I'm sure we've got a lot of questions that have come through, and hopefully you and the other panelists will be able to help us to understand a bit more about the new standard. Maybe I'll ask the first question. I think, Erin, this might be something you might be able to help us with, and I'm wondering maybe even Peter, who might be able to talk to this a bit as well. Somebody had asked about the differences between the existing standard that had happened previously to the new standard. And if there's any crossover from the old standard to the new SCI standard. Erin or Peter, do you think either of you would be able to handle that?
Peter, can I defer to you only because I only really know the new standard and not the old standard. From my understanding, there was an acute standard and a rehab standard that didn't really talk about the integration and that, big picture point of view. But maybe I'll turn it over to you to talk about that transition between going from 2 to 1.
I don't know if I have all the information, John, and I'm not certainly a recipient of actually applying standards, but I will share, from talking to colleagues and such, there was some comments around, how, spinal cord injury is evolving and there's an evolution. We had to look at expansive ways and what best practices can be available to our programs and rehabilitation centers. So, providing innovation to what we currently had in the sense of bringing new technologies or bringing new therapies into a consistent way across every rehabilitation center was one remark that I've heard in conversations. Secondly, I've heard remarks that, the first standards to these standards were easily achievable in the survey, and there could have been more rigor attached to how people were scoring. Was another piece of feedback. So again, I'm hearing these things secondhand because I have conversations with a lot of the hospitals and at conferences and such. But really, I'd be looking at the program supervisors to provide us with a better understanding and over time being able to compare the major differences once these new spinal cord injury accreditation standards are applied.
Thank you, Peter.
Thanks.
I just realized that Andra is here as well. We had her pre-recorded, but she's here with us live now. I wonder, Andra, do you have anything you want to add to this?
Absolutely. Thank you so much for your flexibility and for the opportunity to contribute to this really great forum and this great panel filled with experts. The little bit of expertise that I have is really pertaining to that standard development process. So, John, I'll pick up the question and just say a couple of things just to supplement what Peter's already mentioned. So, when we undertake a standard development as a national standard of Canada, we want to make sure that it responds to the public need. And the public need really shone through that needs assessment and all of the great work that happened before the national standard. So really one of the major changes was to adapt the current state. So, Erin mentioned there was a standard for acute services and one for rehabilitation. So really bringing those together, that was a really big shift, but one that's really needed, as we heard from Canadians. And then the other piece is, as we're going through that development process, one of the things that we have to do as our due diligence is just validating that the information that's present there is still, the best evidence that's available. And I think working through with the advisory committee and the technical committee, we identified collaboratively new evidence and some new best practices that we needed to integrate. And so that's kind of what I can say around the changes and the reasons for some of those changes. This standard is also meant to be complementary and read kind of side by side with some more clinical practice guidelines. So we have to kind of remain flexible to the changing environment, the new evidence. But what we do know impacts safety and quality. That's what you see evidenced in the standard.
I can also jump in here, John. I'm Vanessa Noonan. I work at Praxis as the Director of Research and Best Practice Implementation, and have been part of these new standards, and was also very fortunate to be part of the first standards, and where we had the acute and the rehabilitation. And with the rollout of those, so Praxis supported the rollout of the acute SEI standards that Andres mentioned, and the rehab standards. And those went forward very much working with the acute care standards, the acute care centers for the acute standards, and the rehab centers for the rehab standards. But what we heard when we listened to people with spinal cord injury, that it really did not provide a smooth journey for the individuals over their care, and really didn't reflect some of the priorities that they had. And so what it made us think is that we really needed to evolve the standards, which were created very much from clinical best evidence at the time, to a person-centered approach. And you will see dramatic shifts, very positive shifts in the introductions of peers, in the introduction of providing rehab, thinking of it from the time of injury is when rehabilitation starts, whereas in the other standards, it was more seen as when you got to the physical rehabilitation center. And as we know, not all individuals get discharged to inpatient rehab. And so this new standard really puts the perspective of the person's journey and meeting them where they are and what their priorities are. And so very excited about this shift. And I think in John, in our engagements with people around the world, I think we're one of the leaders, Canada is, on this sort of new person-centered journey. So happy to answer any other questions after the webinar as well.
That's great. Thank you, everybody, for we got a very good answer when we put everyone together there. And just on that note, with the people-centered, is it family-centered as well? How family-centered is this new standard? And I'm not sure if anybody wants to jump on.
Can I start?
Yeah.
So something that HSO is really, really proud of is our people-centered care kind of philosophy and approach. One of the ways that we kind of operationalize that, and you'll see that through the standard, is how we consider the team to be inclusive of the person that's receiving care, as well as, it might be called different things. It might be family, it might be a designated support person, could be a caregiver, could be circle of care. But, what that really means is that decisions are made collaboratively. There is informed decision making, and also the needs, goals, and preferences of the individual that's receiving care, and alongside whoever that support looks like, is considered. People-centered care also really relies on the relationships between the person receiving care, person providing care, and who's involved in that delivery of care. So those are all things that are woven in throughout the content of the standard, but you'll see it probably most specifically around, in the guidance around how do you create services that really respond to the needs of the environment, i.e. through needs assessments, through, integrating feedback from your clients into your quality improvement plans. So those are just some examples.
Does anybody want to touch on any other aspects of the family-centeredness of the new standard, or can I jump to the next question? All right. Well, thank you so much, Andrew. That I think clearly provided the context we needed. And I do agree, we wanted to ensure that this was a very holistic approach. We wanted to ensure that when we think about the spinal cord injury, we think not just about the individual themselves who experiences a spinal cord injury, but a spinal cord injury affects their entire support network, their family and their friends, and they're experiencing a unique trauma that is maybe different than the individual who had the spinal cord injury, but it is a trauma nonetheless. And I think we need to ensure that they're being cared for as much or in a different way than the individual with spinal cord injury is. Next, we've got a few questions that have come through in the Q&A for Amy, and maybe I'll combine them together, Amy, for you into a sort of a singular question. So maybe hopefully you can remember all this. But there was a few that came in. One wondering about interacting with primary care and community programs. So obviously thinking about not just what's happening in the specialized centers, but also the people that these individuals are interacting with on a daily life, their day-to-day life. As well, you mentioned briefly about travel clinics, and I think some people wanted to know a bit about the supports and services that are provided in these travel clinics, and how people access them. And then lastly is around your time commitments to this. I'm not sure the acronyms, but they wanted to say you spend on IP versus OP. So hopefully you understand what that means, because I don't.
Inpatient and outpatient, I think.
That's what I would interpret as well.
I should have known that.
So I guess I'll start with a question around primary care and community care. Right now, we're kind of just in the initial discussion stages. We're trying to make it so that all individuals are connected at least to our outpatient clinic here, from inpatient rehabilitation. And then hopefully, there's some connection with the community OT or PT at discharge. We are trying to look at some of what's been done in the IEQCC as well, in terms of making sure that there's like a checklist that if you go to your provider, so our patient-oriented discharge summary does help that. They can go to a provider, they have this information about possible complications, things that are happening and what they should do. The real focus for us right now is just like making the connections, because we do have a lot of more rural areas, and physicians, well, I can't say physicians, but allied health that don't necessarily have a lot of spinal cord injury experience. We're really trying to make the connections there and provide them with more education on what we can do, how we can help. And the bigger picture, hopefully in the next couple of years, will be that the transition just automatically happens. So right now from inpatients, we automatically kind of refer to community resources or community clinics. And then, but from acute care, if somebody is discharged without coming to rehab, we're trying to connect with them a bit more to make sure they are captured as well. So it is very much just in the initial phases. With regards to inpatient and outpatient, it does vary. I do actually do a little bit of a clinical component, where right now I do go down to the spinal cord injury, or I'll say our rehabilitation medicine clinics on the days that all the individuals with spinal cord injury are booked. So I will do some follow-up there. I do lots of consultation with inpatients. Most of the quality improvement work right now is specifically on inpatients. So that's where I do spend a bit of my time. I meet with all the individuals when they first come in, introduce myself, provide some educational material, and then I'll follow up with them as needed throughout their stay. So it kind of varies, but it is split between both inpatient and outpatient, depending on what the need is. With regard to the travel clinics, so this was an initiative that we started maybe 2-3 years ago. So we found that individuals, it's not just for spinal cord, it's a rehabilitation travel clinic, but individuals with spinal cord injury are included in it. So we have a team that travels. It's a physician and an OT and a PT, and they travel to Labrador area and Central area right now, and they will see individuals in that area who have rehabilitation needs. It is a referral process, and usually it's either clinician driven or like physician driven. So the teams there know of individuals who they want seen. They'll send a referral. Our team will actually do like a little huddle or a meeting with the teams there before patients are booked, review the cases. Then they're booked within a clinic and they're seen over a couple of days period. So they might be in Labrador for 4 days and see a number of patients every day while they're there. Then they'll go back every couple of months and do any kind of follow-up. But it's also a great way to educate the teams there, because now they have a better understanding of the conditions they're seeing, and they're also able to follow up themselves on some issues, or they can reach back out to us regarding those. I think that was all the questions, and I hope I answered them without talking too fast.
Absolutely. Thank you very much, Amy. And I'm just looking at the time. We've got time for one more question. And given the standards cover transitions in care as well as community services, where does the responsibility lie given the institutions being accredited or acute and rehab hospitals only. And Andrew, are you able to speak to that?
It's a really great question, and I'll do my best, but we'll look to the group and see if there's anything that I'm missing. But essentially, accreditation is not mandatory in the majority of jurisdictions in Canada and internationally. We know that it's a challenging kind of activity to undertake. There's a lot that goes into it. But we also know that it's really important to drive organizations to quality improvement. So whatever we can do as a group to try to encourage and promote the use of this standard across some of those organizations that are perhaps not yet accredited. And it doesn't need to be formal accreditation through Accreditation Canada. If there's an interest in quality improvement, then this standard is a really great place to start, and provides really actionable recommendations and guidelines for those organizations to be able to begin their quality improvement journey. Whether that involves accreditation, I mean, that's kind of an end goal for many. But, as Aaron mentioned, there are kind of business development individuals who can support organizations to reach that goal. Any other thoughts?
Thank you. Thank you, Andra. Peter, were you about to say?
No, I just wanted, I wanted to just comment on just building on what Andrew was saying in the sense where, while this is a voluntary process for accreditation, we're all collectively trying to create the most optimal SCI recovery for everyone with a spinal cord injury. And we know that the system of services in our healthcare are sometimes challenging with the resources and capacities that we have to achieve the highest optimal services for people with spinal cord injuries. And if we work collectively together through a standard of practice, we can achieve a higher standard, and that's the purpose for creating these standards in the beginning.
Thank you, Peter. Thank you so much, everybody. We're just got 1 minute left, and I wanted to, just a sec here, I'll get my screen back up. There you go. I want to let everybody know that we're sending a link to everybody who's registered for this recording and some resources to learn more about accreditation. And any questions that we haven't been able to answer, we will follow up with some answers to those as well. And for those who indicated they would like to be contacted in the future, we'll continue sending you resources regarding the national standard and related, and we'll also post updates on our website at praxisinstitute.org. If you're watching the recording, please contact us at praxisinstitute.org to be included in our mailing list. And we have a poll up on the screen there. If you don't mind giving us some feedback about the webinar and anything else that you would like to see, more information that you'd like to have regarding standards, accreditation, or anything related, please leave that feedback there. And I thank everybody so much for coming and hope you have a wonderful day.